Hello, everyone. My name is Denrong Jiang, and I'm a postdoctoral fellow at the Johns Hopkins University. Welcome to the Imaging Cerebral Physiology webinar series. The purpose of this webinar series is to showcase the latest research related to ICP, and also importantly, to help us stay connected despite the pandemic. We hope to have a monthly webinar on the fourth Thursday of every month at 10 a.m. Eastern Time. And these webinars will be recorded. So if you are unable to attend, you can always check out our YouTube channel. And if you are interested in learning more about future webinars and any updates related to the ICP community, please sign up for our ICP newsletter. And today is the first webinar of the series. Our next webinar will be held on May 27th, and it will be ICP highlights from the ISM meeting. And we will invite a few ISM presenters to give us a more detailed presentation of their work. And to organize this seminar, we have a team of 5 people, including myself, Michael Jimashka from Cardiff University, Brittany Insand from Concordia University, Rachel Stickland from Northwestern University, and Greg Wheeler from University of California, Davis. So if you have any suggestions for the webinar, please feel free to contact us. Here are some reminders for today's presentation. During the presentation, please stay muted and turn off video. And we will have a Q&A session at the end of the presentation. And you are welcome to use raise hand function to ask questions. Once you raise hand, the moderator will ask you to unmute so you can ask questions to the speaker. And please feel free to contact us if you have ideas for future webinars, or if you have any announcements that are relevant to the ICP community, we will be happy to circulate them. Now I will hand it over to Rachel Stickland. She's our moderator today. Rachel.
Thanks, Dangrong. Yeah, I'm Rachel, another organizer, and I'm very happy to introduce our first speaker of our webinar series, Dr. Hanzhang Lu. So Dr. Lu obtained his bachelor's degree in biomedical engineering from Shanghai Jiao Tong University in China. His doctoral degree, also in biomedical engineering, was at Johns Hopkins University. After a period of short postdoc training at New York University, he joined the faculty of the University of Texas Southwestern Medical Center. And in 2015, he returned to Johns Hopkins, promoted to Professor of Radiology in 2016. In 2020, he became the inaugural recipient of the Ilyas A. Zerahuni MD Professorship and now serves as the Chief of the Neurofunction Section in the MR Research Division within the Department of Radiology. He's a 2018 Fellow of ISMRM and 2019 Fellow of the American Institute of Medical and Biological Engineering. So it's great to have an expert in imaging cerebral physiology to kind of start our webinar series. So Dr. Lu really leads kind of technical development in this field, as well as kind of applying these advanced methods to clinical populations. So I'm really excited to hear about that today. So thanks for starting us off, Dr. Lu. I'll hand over to you now so Dengrong can stop sharing his screen and you can take it away.
Thank you very much, Rachel, for a nice introduction. And thank you everyone for participating in this webinar series. It's really great to see so many old friends and get to know some new friends through this platform. Everyone can see my screen, I presume. Let me start the, okay. So before I jump into today's specific topic, I thought I want to give a brief sort of description of my understanding of imaging cerebral physiology. So in my view, MRI technology has 3 categories. And the most widely used one and the most well-established ones are these category 1, what I call category 1. These are bread and butter of sort of neuroradiology, private practice, community hospitals. They do things like T2 FLAIR MRI. And if they do contrast agent, they often do a T1 post contrast. These, again, they are the bread and butter from a neuroradiology point of view. And then there's also a second category of MRI techniques. I call it quantitative anatomical and structural MRI. These are the MP range, MP2 range, multi-echoing range, the DTI that we have seen performed in many brain research studies. Almost every neurological and psychiatric study apply these sequences in their study. And many major multi-site trials such as UK Biobank, ATNI study, ABCD study, they all use these tools because they are quantitative and they're reliable. And then there's the third category of technique, which I can broadly put them into physiological and functional MRI category. And these are the perfusion and the CVR that many of us are doing, measurement of metabolism, resting state, fMRI, and other more advanced physiological and functional MRI techniques. These are sort of still in the either technical development stage or in the initial clinical application stage. They really haven't made it to the, let's say, the major neuroscience community in terms of those big multi-site trials, and certainly haven't made it to the community hospitals, to the neuroradiology field. And in my view, one major goal of our research, or our career in a sense, is to move some of these techniques from category 3 to category 2 and eventually to category 1. For instance, it would be nice if one day you have a button on the scanner in a community hospital saying, we're gonna measure metabolism. That would be nice, and that can be used to diagnose things like dementia, multiple sclerosis, things like that. I think so. That's the goal of much of our research, and in a sense, it's goal of our field to move these to really go to patient care and to make an impact in healthcare. So indeed, our field is quite active. In 2019, I see Peter Bandittini is also, I think, in this webinar. He invited me to organize a special issue on physiological MRI, and many of you in the audience have contributed to various studies and techniques that described in that special issue. And we are also a group of people who are very passionate about meeting each other and exchanging research ideas. So as mentioned, this group called Imaging Cerebral Physiology has been meeting every 1 or 2 years in person prior to COVID. And the latest one was held in Johns Hopkins in Baltimore in a couple of years ago. So with this sort of brief introduction about the Imaging Cerebral Physiology field, I will move on to what my main topic is in terms of this seminar. So I'll be talking about 2 techniques that our lab has been working on over the past few years. One is to measure blood-brain barriers permeability to water molecules without using contrast agent. And the other is to use MR fingerprinting idea to apply to arterial spin labeling for a hemodynamic sort of assessment of the brain. So let me talk about the first topic first. Blood-brain barrier permeability, obviously that's an important topic in many brain diseases. It ranges from Alzheimer's disease, multiple sclerosis, tumor, and other many disorders of the brain. And traditionally, you know that BBB permeability is measured with gadolinium contrast agent. And although it has been used quite widely, it also has room for improvement. For instance, the one limitation is that it causes allergic reaction in some people. There's also a skin disease or skin condition called nephrogenic systemic fibrosis. And there's recent evidence of long-term deposition of gadolinium contrast agent deposit into the brain. Whether that's doing anything bad to the brain or not, we don't know, but at least it's depositing in the brain. And then there's pragmatic issues of doing contrast agent enhanced MRI, such as difficulty in doing IV, missing timing. Once you inject it, then there's no coming back. You cannot repeat it. And sometimes patient consenting is also an issue. So therefore, there is a pragmatic reason that's there to develop a non-contrast based method to measure blood-brain barrier and to water. And there's also a scientific reason. Well, gadolinium is a molecule of 550 Dalton, and water is a much smaller molecule. So therefore, if you can measure blood-brain barriers permeability to water, you can essentially get a different view, different perspective of the BBB function in our brain, and potentially can be used for early detection of more subtle BBB leakage in diseases. So those are the sort of motivations for this kind of techniques. And BBB permeability to water has been measured, has been proposed to measure in quite a few studies. One is to use control agent. I said gadolinium has been used to measure the BBB permeability to gadolinium molecule, but it has also been used to probe the water's permeability. And there are quite a few studies previously using the so-called fast exchange regime. Essentially, the idea is that once the gadolinium molecule is in the blood vessel, the water will exchange across the capillary area, capillary region, and then depending on how fast the water exchanges, you can see more T1 reactivity from the gadolinium. So essentially, that's based on fast exchange regime of water molecule, and has been applied in some diseases as well. And more recently, there's also a lot of interest to use ASL-based method to measure BBB permeability to water. So we are not the first one to measure it. Other people have done that. And for instance, there's a few group, Danny Wan's group and also Xiang He's group. They've used diffusion-based method to measure ASL signal in capillary, and then from that they can estimate BBB permeability to water. And there's also using T2-based method, Jack Wells' lab and Matthias Gunther's lab have tried to use T2 property difference between intravascular and extravascular spin to essentially measure the BBB permeability to water molecule. So today I will just present the method that our lab has been working on. So principle of our method is that you label the arterial blood coming from arterial side, use let's say ASL, typical like ASL methods. And then when we reach the capillary, some of the water spin will exchange to the tissue and others will remain in the vein. And our method is that rather than trying to measure the ASL signal in this region, we wait until these spin flow into venous side. Then we can measure the venous signal in terms of ASL, in terms of arterial labeled spins. So this is the basic principle of our technique. If you put it more into a mathematical model form, it shows like that. You label here, and then you wait for the ASL spin to reach the vein. And as I mentioned, majority of them will be exchanged through capillary to enter the tissue. A small fraction of them will remain in the vein, and there's also some re-exchange, which we can also consider. And then you can see signal like this, and you can measure the signal intensity in the vein and to see how much spin has indeed remained in the vein. And mathematically, you can do this kind of experiment at multiple post-labeling delay time, just like in ASL case. And then you can fit the signal to this model to you estimate this E. It's called water extraction fraction. How many % of the water molecule has entered the tissue? So essentially this is 1 minus E. So once you know the E, you know essentially the exchange rate. And we also get to this bolus arrival time, the time it takes for the water to come from arterial side, go from arterial side to the venous side. That's also sort of a byproduct of our fitting. Once you know the E, then you can use this equation, which use E, but also requires the cerebral blood flow, CBF, to estimate this index called permeability surface area product, which is the index of the BBB's integrity or BBB's permeability to water molecule. And in this case, for instance, in this case, we are talking about a global whole brain measure of BBB permeability to water. And for blood flow, we can use phase contrast MR method to provide a global estimation of CBF. Okay, so this is the idea. How does it work? So we started by doing a simple ASL experiment by using a very long post-labeling delay. As we know, the ASL for perfusion typically use 1800 or 2 seconds of post-labeling delay. In our study, we use very long, up until 4500 milliseconds. And sure enough, when you wait long enough, you can see these venous vessels pop up, and that's the ASL spin that's remained in the vein. And if you do some ROI analysis, you will see things like that. As a function of delay time, you can see bolus come in and go out. And that's true for different segments of the superior sagittal sinus shown here. You can see that the anterior segment, it arrives early, the peak appears early, and more posterior segment of the superior sagittal sinus, the peak arrives later. So this is all consistent with the expectation. One problem is that with this kind of data, this tissue signal become a nuisance. That is, we are not interested in perfusion here. We're interested in the signal in the vein. So therefore, these tissue perfusion actually become something that we don't want. So to remove it, we devised a sequence called water extraction with phase contrast arterial spin tagging WEPCAST, where we applied a bipolar gradient to suppress the static tissue signal. Therefore, we only highlight the vessel signal. We also applied a long labeling post-event delay and pretty aggressive background suppression pulses to make sure the unwanted static tissue signal is suppressed. And we label here, we image a single slice in the mid-sagittal plane to essentially look at the mid-sagittal superior sagittal sinus. And in doing that, we measure the global BBB permeability. So here are some of the results. You can see right away that the control label signal, it shows indeed what we wanted, that the tissue signal is gone. We only see vessel now, sort of like a typical venogram or phase contrast. And then when you do a subtraction between label and control, you see the signal light up. These are not artifacts due to motion, they are real signal. And with different delay time, you can see signal come and go. And if you fit a particular location signal as a function of the model that described previously, you find that for normal people, the incoming arterial blood water, about more than 90% of them actually get extracted to tissue, but there is less than 10% that actually remain in the vein, and that's what we are measuring here. And then if you combine this E measure with blood flow, as I said, you can get estimation of the permeability surface area, a real index of BBB permeability, which is around this range. But one problem is that this scan, takes 20 minutes. So that's too long for clinical applications. So that's when we decided to kind of improve our technique to make it a little bit shorter. What we did is that we developed a single delay webcast sequence, and let me explain that. So shown here are the spatial temporal dynamics of the signal in these veins. For instance, if you look at this anterior segment of superior sagittal sinus, you expect to see a bolus coming in and go out. And then as you go to another location, you will see also bolus coming in and go out. But because this is located at a more posterior segment of the superior sagittal sinus, the peak will appear at a later time. So therefore, this kind of thing can go on for more posterior segment of the superior sagittal sinus. If you do a sort of a single scan at this time point, you will see that there is a spatial distribution of the signal as a function of the location along the superior sagittal sinus. And if you do that experimentally, you can draw a region of interest like this and look at its signal, and indeed it looks like this. You will find the peak in the middle of the bolus, and that's where sort of the most signal is. And so that gives the signal that you want to measure. Importantly, once you know the peak here, you know that because the peak is in the middle of the bolus, it corresponding to a bolus arrival time of this post-labeling delay plus half labeling duration. So that means you don't have to fit for this additional variable anymore. You know this is already known. You know this is half the labeling duration plus the post-labeling delay. So then the equation only has one unknown, which is E. So therefore, just by using this signal itself, you can estimate the E extraction fraction. And then of course, you can go on to measure PS. And we indeed did that. And from this single delay method, which takes only 5 minutes, compared to the more the multi-delay, more time-consuming method, which takes about 20 minutes, you can see that their correspondence is pretty good with a slope almost close to 1. So that means this technique can essentially work without needing multiple delay. You ask, this is a manual join of RY. How does this RY join affect the result? And we did ask two raters to draw the same data, and you can find there is a nice correlation between the two raters' result. Another thing we consider is that like other MRI techniques, physiological MRI also sort of suffer from some variability across scanner and across platforms. So we also try to implement this technique on both a Philips scanner and a Siemens scanner. And we did this retest reproducibility study. What we did is that for each person on scanner 1, they would do a session 1, and we pull them out, give them a break, and then put them back for a session 2. And then they walk to another scanner, which is different vendor, and do the same thing. And within each session, we would repeat the WEPCAST scan twice. And that will allow us to assess the intra-session, inter-session, and inter-scanner reproducibility. Shown here is the data from a representative subject. You can see that from Philips scanner and the Siemens scanner, the data are quite reproducible. And when you look at the spatial profile of the signal, they're also reasonably close to each other. And then here is the quantitative assessment of their reproducibility. Intra-session, meaning you don't reposition the patient. The variance is about 6%, coefficient of variation about 6%. And when you reposition the patient, on both Philips and Siemens scanner, the variance is about now 7%. And then for different scanner, the variance is indeed bigger, about 8 to 9%. But in general, I think this kind of variance for a physiological measure is generally considered pretty good, because physiological measure in general has a higher variance compared to anatomical or structural measures. So as I mentioned previously, there are also some previous technique to measure BBB permeability to water using conscious agent-based method. I should mention those methods are not considered gold standard because there are also some issues with those methods. But nonetheless, those represent another way to look at BBB permeability. So it's good to compare them. So here we compared our WEPCAST method with those GAD-based methods. You require some injection of conscious agent. Before that, you do a few scans to get a baseline. Then you inject the conscious agent and then continuously measure the signal for about 25 minutes also. And then you can get a PS estimation from the conscious-based method and compared to the non-conscious-based method. So you can see that there's in general a correlation between these two. As I said, neither is considered gold standard. So which one is more accurate, we don't know, but at least across people, they seem to show a nice correlation. And the conscious agent-based method takes 27 minutes and the WEPCAST method takes 5 minutes only. So let's look at some clinical applications. Before that, let me say what are we doing in terms of the technical advance. So what we are doing now is that we used to use 2 seconds of labeling duration for the ASL labeling. Now we are trying to use higher labeling duration. And you can see that when you use longer labeling duration, indeed the signal becomes higher. And then when you look at the signal, for both anterior, middle, and posterior segment of the sagittal sinus, you can see the signal becomes sort of stronger compared to a shorter labeling duration. So now we are routinely using 4-second label duration for our WEPCAST sequence. Another small advance that we are making is that we previously have been primarily trying using AP encoding in terms of phase contrast to look at essentially vessel running AP direction. Now we are also trying foot and head. And in general, we found that foot head give a bit higher signal noise when we use this technique. So we are now using foot head in combination with labeling duration of 4 seconds in our sort of more recent studies. Now let's look at some clinical applications. We first applied this to Alzheimer's disease. We recruited a group of mild cognitive impairment patients, which is a sort of early form of Alzheimer's, and compared to a group of older controls. Their age is matched and the sex is also roughly balanced. We found that MCI patient has higher PS, indicating sort of BBB leakage in these patients when compared to older controls. And if you look at their cognitive function, we also found that individuals who have higher PS indicating leaky blood-brain barrier, they tend to have poor memory performance. We also found a similar relationship to this composite. Let me see. I'm muted somehow.
You're back now.
Oh, I'm back now. Okay.
Yeah.
Okay. So we also look at the composite of cognitive function. It's also related to PS. Again, leaky blood-brain barrier indicating poor cognitive function in this patient group. In this patient, we also did something called lumbar puncture, where we put a needle into the cerebrospinal fluid and draw some CSF. From CSF, we can assay the so-called A-beta 42, which is an indicator of amyloid burden in the CSF. And we found that there is a significant association between amyloid burden and the BBB permeability, indicating again, seem to suggest that these BBB permeability damage is related to AD pathology. The second example I want to show for this is sickle cell disease. Sickle cell disease is an inherited red blood cell disorder where they start with a gene mutation and then they produce this non-typical hemoglobin called hemoglobin S, which aggregate and form polymer and then causing this cell shape to deform. And they have issues with cerebrovascular microcirculation. So we work with our collaborator, Dr. Lance. We recruited a few pediatric sickle cell patients, also a small number of healthy controls, but that's still small. What we found is that in general, WEPCAST MRI work very well in sickle cell patients. The signal actually is very, very robust, and we see this kind of signal in almost every patient. And we found that there's more signal in sickle cell patient compared to controls, and that translates to sickle cell patient has lower extraction fraction. You see that less than 90% is being extracted, as opposed to in healthy controls, more than 90%. We also know that a sickle cell patient has higher blood flow. When you combine blood flow and E, the result is actually that we found a sickle cell patient has higher permeability surface area, which indicating, again, BBB leakage in this population compared to controls. So one limitation of the study is that we only have a small number of healthy controls, and also it's not sort of gender balanced. So then in the following study, we just look at the patient themselves. What we found is that sickle cell patients also often have ischemia, have low hematocrit, anemia, I should say, low hematocrit, low hemoglobin. So indeed, you can see that the more anemic they are, the more leaky the blood-brain barrier is. So that's consistent with the expected change. Similarly, this hemoglobin S is the abnormal form of hemoglobin. You can see that the abnormal form fraction is higher, that also corresponding to a leakier BBB permeability. So this indicating BBB permeability plays important role in the pathogenesis of sickle cell. And finally, in this sickle cell study, we compared a subgroup of patients who have these flare hyperintensity, we call it silent cerebral ischemia, versus those who don't. And you can see that those who have silent cerebral ischemia has a higher PS, again, suggesting that higher PS, leaky BBB is bad in sickle cell disease. So take-home message number 1. BBB permeability to water may provide a new perspective of BBB function. And I hope I've shown that this can be measured, at least globally, with our method without needing to do conscious agent injection, and it can be done within 5 minutes of time. And in a couple of cases, we showed that BBB permeability is increased in brain diseases. Okay, the second half of my talk will be on MR fingerprinting, arterial spin labeling, MRF ASL. I think people are more familiar with ASL. In 2015, a group of investigators published a so-called white paper. Actually, it's called recommended implementation. And basically, in that white paper, people recommend how one should acquire ASL and how we should compute CBF with ASL data. And that has really been helpful in pushing ASL to wider clinical application in this field. And to date, the paper has been cited by more than 1,300 times. So that has been a good success. But technology development should still go on. So the reason is that the kinetic model of perfusion is quite complex. Even though we try to ignore all the other things, but actually the ASL signal is not just affected by CBF, it's also affected by bolus arrival time, tissue T1, arterial blood volume, and other things. So therefore, we still have a job to do in terms of improving ASL technology and ideally measure all these together. That can not only improve the estimation of CBF, but also provide additional information that could be indicative of disease as well. And that's the motivation of sort of our study. And the method we are using is called MR Fingerprinting ASL. Well, what is MR Fingerprinting? The idea of MR Fingerprinting originally was proposed by Ma et al. In their Nature paper in 2013 outside the context of ASL. That was mainly for structural imaging. And the idea is that similar to a fingerprint code database, you have a signal that's sort of designed using a special combination of TRT time series. But once you get the signal, you go to a dictionary. You go to dictionary to find which signal in the dictionary is optimally or maximally match the experimentally acquired signal. Once you get that, then the corresponding parameter that's used to generate this signal, generate the dictionary item is assigned to this voxel. So you can simultaneously get T1, T2, proton density, etc. in a single scan. And we essentially adopt this idea to the context of ASL. So shown here is conventional ASL, where you have label, weight, and then acquisition, control, weight, and acquisition. In MRF ASL, they are purposely sort of randomized. You can see that label and control is no longer strictly paired. They are randomized. And the duration of these blocks is also somewhat varying, not totally fixed. And then we don't use post-labeling delay. And the idea is that rather than in the conventional ASL where you label here and measure here, we label here and measure a few TRs later. So that's essentially hopefully make it more efficient in terms of acquisition. And so this is a sort of new sequence that should be interesting. I should mention that actually Luis Hernandez Garcia's group at Michigan was the first one to propose this kind of idea, MRF ASL, in their 2014 ISM abstract. And we essentially followed on their work. And shown here are typical labeling duration diagram. Essentially, it varies from one TR to next. It doesn't, we don't fix the labeling duration. Shown here in the blue curve is a representative signal from this kind of pulse sequence in a gray matter. And the red signal is the dictionary item that optimally match this experimental data. Once you find the match, then the parameters that's used to generate this red dictionary item is assigned to this voxel. And to generate this kind of dictionary, you can use different models. You can use something called one compartment model, which only has blood vessel and tissue. You can also have a two compartment model, which there is a passing through artery, which happens quite a bit in a typical voxel. That is, the blood that doesn't go to perfuse this voxel, but actually is on its way to somewhere else. But it happens a lot. And you will see the benefit of adding this second compartment. But what's nice is that with the same data, you can try a different model and get a bunch of parameters. So a 3-minute scan can give you all these maps in one scan. You can see that there's the B1 map, the T1 map, blood flow map, this is so-called bolus arrival time map. And with two compartment model, you can even get more. You can see, for instance, with adding a second compartment, the large vessel signal in the CBF map is now gone. You can sort of getting close to the perfusion. For tissue BAT, you can see it's noisier because tissue signal is weaker compared to large vessel signal. And so because some of these maps are redundant and some are not particularly sort of robust, in our later study, we decided to focus on 4 of these maps: blood flow, bolus arrival time, T1, and B1. And shown here also is comparison with more traditional single delay ASL and multi-delay ASL. You can see just by maps, you can see we have more maps with our MRF ASL method. And even with multi-delay, the bolus arrival time doesn't have the necessary contrast between gray and white, whereas here we have a nice contrast between gray matter and white matter. We also did a couple of optimizations for this pulse sequence. One is flip angle. We want to decide what is the optimal flip angle, because we don't want to use 90 degrees, because we want to allow some signal to go from one TR to next. So we don't want to utilize all the magnetization in one TR. So we did a different flip angle from 10 degree to 90 degree. And in general, you will see that when the flip angle is low, you essentially have very noisy BAT map here. When it's very high, you can see that when it's 90 degree, you can see that this large vessel is too prominent, because essentially you are overemphasizing on large vessel. And we determined that 40 degree seemed to be a good compromise, where you have a good SNR and also large vessel is not so prominent here, and SNR is good enough. The second optimization we did is on the TR. Like I said, the TR is varying, but there are like infinite number of combinations of TR series. So we just thought we try a few to see whether there's any golden sort of silver bullet that we can find out. So we tried 10 different TR series. Each has 500 TRs, but some are descending, some are ascending duration, some are a bit more kind of polynomial, some are sinusoid, and some are more random number generator with different distributions, and one is constant. You can see that the constant one, number 10, clearly doesn't work. The other one, they all work, pretty well. Some are a bit worse than others. And by looking at its spatial correlation, we found that this number 4, which corresponds to sinusoid fluctuation, seem to give the most reliable estimation. So, and that's what we've been using for future studies. Many of us in this audience are familiar with CO2 inhalation. We know that hypercapnia will increase blood flow and decrease bolus arrival time. And that's indeed what we found with this. You can see that with the same scan, we'll do a 3-minute scan with room air and then do another 3-minute scan during hypercapnia. You can indeed see that blood flow map become brighter and the bolus arrival time become shorter. So again, this is sort of confirmed that what we are measuring seems to be what we think it is. How about comparison with contrast agent, something called dynamic accessibility contrast MRI? Shown here are the comparison between them in the same participants. You can see in general, the map are fairly similar for CBF and for bolus arrival time. One note to comment is that even though the map looks similar, but actually the absolute value seem to be different. And sort of sidetrack to another point is that many of us are also using CO2 bolus to measure the bolus arrival time. And we often find that the bolus arrival time measured with CO2 can be, for instance, white matter can be 20 seconds longer than gray matter. And this has been sort of a pattern. That is, we found that when the bolus is short, your bolus arrival time difference is also fairly small. Like this is 1 second bolus, you see this difference about 2 seconds between gray and white. When you do a 4 to 8 seconds bolus injection, then that's about up to 5 seconds. And when you use a 30 seconds CO2 bolus, then the gray-white delay could be up to 20-some seconds according to data. So anyway, the contrast-wise, they are similar. And if you do region of interest analysis, divide the brain into 100 regions also, they also show pretty good consistency between the MRF ASL and gadolinium-based method. Let's look at a few clinical examples. So first, I want to show this Moyamoya disease. Moyamoya disease, as you may know, is a arterial stenotic condition. And shown here is an angiogram of a normal person. You can see that the internal carotid branch off to middle cerebral artery and the anterior cerebral artery, and then the vertebral artery go to basilar, becomes the posterior circulation. But in Moyamoya patient, as you can see, the middle cerebral artery and anterior cerebral artery, they are gone, they are blocked. And if you use MRF ASL to measure them, you can sure enough see these kind of very different pattern. So first row is the bolus arrival time. You can see very dramatic difference that is in patients who have bilateral stenosis like this one. You can see that the bolus arrival time map is substantially lengthened compared to healthy control. And when you have unilateral stenosis, and it's only this side that has longer bolus arrival time. So bolus arrival time seems to be very sensitive in terms of detecting these blockage and stenosis. And we also found that actually the posterior circulation have a little bit shorter bolus arrival time compared that to the normal control, presumably due to compensation or collateral flow, etc. Blood flow in our hands did not show an obvious difference, at least for group comparison. T1, visually you don't see anything, but if you do statistical analysis, the Moyamoya patient show a little longer T1, presumably indicating some kind of edema. You can compare the MRF result to more traditional clinical imaging of MR angiogram scores. You can see that more severe stenosis indicated by higher score corresponding to longer bolus arrival time. And you can also compare to the phase contrast flow measured in the major arteries. You can see that a smaller flow corresponding to a longer bolus arrival time. We also look at such relationship with blood flow. We found that blood flow relationship to flow or to score is not that significant. Another important application of a biomarker is to assess treatment. Shown here is you want to use MRF ASL to assess the neurosurgeon's treatment by doing something called a bypass surgery. We have two patients, patient 1 and patient 2. Patient 1, you can see that before operation, they had a left brain stenosis, and then you can see that the bolus arrival time is lengthened in this region. Blood flow also shows some heterogeneity, some are low, some are high. And then neurosurgeon opened the scalp, drill a hole, and then put an artery from the outside the brain into the intracranial space, and hoping they will grow and to perfuse this territory of the brain tissue. And sure enough, 3 months later, you can see that it is precisely in this location where the neurosurgeon put in the artery, you can see the bolus arrival time has shortened. The more peripheral areas still have some deficit, but it's in this kind of surrounding the new artery region there's improvement. And also the blood flow map becomes more homogeneous. The right-hand side is patient 2, which they received something called an indirect bypass. In this case, the neurosurgeon only drill a hole on the skull. They didn't actually insert any artery into the intracranial space. You can see that in this case, the improvement is slower. This is 3 months, and I think 6 months after the operation. The improvement is slower, although you can see there's clear improvement, but just takes more time. You can see gradually the hypoperfusion region become brighter and brighter. So these kind of things indicate that MRF ASL may be useful to evaluate surgery treatment efficacy. Come back a little bit to the technical aspect. Like other ASL implementation, one of the drawbacks of the MRF ASL is that it has relatively low SNR. Sometimes it's a little noisy. And there has been recent effort to use artificial neural network, or you can call it deep learning, to improve the SNR of these maps. And some prior work, this is the work from Michigan, and this work from a group in Tsinghua University in China. They've used, both of them used simulated data to train the network and then apply it to the in vivo data. We saw that because brain hemodynamics is complex, the simulated data may not fully capture the signal behavior of the ASL data. We said, why don't we use a experimental data set to train the neural network? And that's indeed what we did. We acquired something called high-fidelity experimental data. What we did is that we just run massive averaging of the run. We run 10 ASL scans for a total of over 40 minutes. And then we can average them, get this high-fidelity signal, and then use dictionary matching to get the high-fidelity CBF map, and use these to train the neural network, then apply it to testing data. Shown here are the testing data results. They are not training, they are testing data result. You can see that the ANN-derived map are sort of higher SNR compared to dictionary matching method. Same thing can be said for the bolus arrival time map. It's sort of more reliable. And in particular, you can see these dark dots that's present in the dictionary matching method now is gone in the ANN deep learning method. And quantitatively, you can calculate the Vox-wise COV coefficient of variation. We find in general, ANN have less variance for both CBF and BAT compared to the dictionary matching method. We said that the in vivo data using high fidelity experiment data is better, but how about compared to the simulation data? Shown here are some simulation data results. They are still experimental data, I should say, but the network was trained with simulation data. These are still experimental results, but network is trained by simulation data. You can see that this is with varying amount of noise added. You can see that when you add too much noise, the map becomes reliable, but then the contrast become a bit weird. It's really artificial. It's not really similar to the actual contrast. And when you don't add any noise, data is quite noisy. You can of course do this, but 0.1 standard deviation of noise, but the SNR I think is still not as good as the in vivo data trained network. How about application? Well, we have used this technique in stroke patient. You can see that in this stroke patient who have stroke on the left hemisphere, you can see the bolus arrival time map shows a nice illustration of the deficits, with ANN method provide more reliable result compared to the dictionary matching, which has again these dark spots. And CBF seems to be similar. Both show the deficit of perfusion in this patient. We have studied 35 stroke patients so far, and you can basically see that CBF is lower in the stroke side compared to contralateral healthy side, and bolus arrival time is longer in the lesion side. And when we look at difference between lesion and control, they actually nicely correlate with the clinical score of NIH stroke scale. Higher stroke scale means worse. So you can see that when you have bigger deficit in CBF, you have worse scale, and we have a longer bolus arrival time, you have worse NIH stroke scale, showing that this is potentially useful for stroke application. So my take-home message too is that when you want to do multi-delay ASL, MR fingerprinting ASL is a good way to potentially do it. It can provide simultaneous estimation of blood flow, bolus arrival time, and a T1. And artificial neural networks can improve the SNR and can improve about 200% according to our data for CBF map and 100% for bolus arrival time map. It doesn't help too much with T1 map. We tried that. It didn't help too much T1 because T1 map is already very reliable. So when it's not very, when it's very reliable to start with, deep learning doesn't seem to help too much. And we've shown a couple of examples where ASL, MRF ASL can be used in cerebrovascular diseases. Well, this is my summary. Our lab is very interested in physiological MRI techniques. Today, I think I showed some techniques to measure blood-brain barrier permeability, blood flow, bolus arrival time, but we are also, as many others in the field, are working on oxygenation method and vascular activity, compliance, etc. Have lots of people to thank. Most of the work in the BBB work was done by Zishuan Lin, who is a postdoc now, was a student in the lab, now is a postdoc, and Pan Shu and Hong Li was the main people who did the MRF ASL work. Finally, I just want to say that at Johns Hopkins here, we have an excellent biomedical engineering program. It's a nice PhD program. And within our radiology department, we also have a big group of MR researchers. This is a photo from a retreat we had a couple of years ago. We have more than 100 people in our sort of MR research area in our institution. So if anyone of you is interested in doing a PhD or do a postdoc, we are welcome to contact people from our institution. And thank you very much for your attention.